गुड इवनिंग। आप साइलेंट हैं। वॉइस वो है। यू आर इनऑडिबल। यू आर इनऑडिबल एक्चुअली। हाँ। कुछ प्रॉब्लम।
Hello.
हाँ, अभी सुनाई दे रहा
Right, right, right.
है।
How are you, sir?
वेरी नाइस।
हाँ,
कैसा चल रहा है सब?
बस सर एकदम बढ़िया एकदम बढ़िया। हाँ।
वेरी गुड।
हाँ, तो
हम लोग का सामने एग्जाम है ना, एसपीयू।
ओके। हाँ, राइट 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 बिल्कुल एसपीयू कौन है? हाउ थिंक प्रिपरेशन गोइंग सर?
या ओके।
ओके।
इट्स मोर देन एन एग्जाम।
या डेफिनेटली once every 3-4 years से ज्यादा frequently
हाँ।
becomes too tiring.
And actually, the main thing is not many people are, we don't get many people in the preliminary stages. Only
Right,
two. We have to slow
right.
it up.
That is true. That is
Both
true.
things will be good. Let us see.
Yeah. No, I think last time I'd attended very well,
Um,
active discussion and all that. That was
yeah, yeah,
really nice. So I'm
yeah.
hoping कि इस बार भी it will
हाँ।
go well.
नहीं, वो सब कंट्रोवर्सी है, लाइव वर्कशॉप का कंट्रोवर्सी।
Right,
दैट बट ओके, वी विल कैरी ऑन, विल डू।
true. अभी तो कर रहे हैं कि लाइव वर्कशॉप नहीं कर रहे सर?
नहीं नहीं, करेंगे, 100% करेंगे।
ओके ओके।
100%, वी डोंट हैव एनी इशू विद दैट।
राइट 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 राइट
वी डोंट हैव एनी डायरेक्टिव फ्रॉम एनएमसी की मत करो।
राइट दैट
We
इज
will
ट्रू।
keep all safeguards. We will try to ensure the best care for the patients, and
राइट
we'll take consents and all. Then we will do it. I mean, there is no issue.
राइट
अभी
राइट।
तक तो प्लान है कि करेंगे।
हाँ।
So what God has in store for us, let us see.
Yeah, that is true.
Yeah. तो कैसे क्या प्लान है? I mean, from एम्स।
हाँ नहीं अभी वो बेसिकली वी नीड दोज इनवाइट्स एंड ऑल दैट
ये
उससे
नहीं नहीं,
पहले।
वो तो
हाँ
भेजेंगे। आई मीन बेसिकली, आई मीन उसमें तो वो है ना, डिपार्टमेंट में कौन कौन, मतलब उस हिसाब से विल
हाँ
अलॉट
नहीं
सेशंस।
या तो 3 of us, six faculty are there, so 3 of us can come.
Okay, so who all? I mean, we can send invite to them with session name and all.
राइट I'll send it over सर, मैं एक बार
आप
डिस्कस
हमको
करके
पर्सनली भेज
I-
दीजिए। आई सेंड इनवाइट, जैसे
ठीक
हमने
है।
दूसरे इंस्टीट्यूट में किया है, एम्स में वगैरह। आई मीन न्यू दिल्ली एंड ऑल, वी हैव सेंट स्पेसिफिक इनवाइट्स विथ नेम्स।
राइट राइट राइट
तो
राइट।
आप जो जो आएंगे, आप हमको बता दीजिए। आई सेंड यू ऑल द लिंक्स एंड ऑल,
डन
and I
सर
will
डन।
send you special invite for the this thing panel or whatever. We might change it later, but now we will
राइट
specify one session.
यस यस दिस इज फॉर बेसिकली फॉर द
For the leave and all. Yeah,
reimbursement.
sure, 100%. We'll expect you very much.
Yes, sir, absolutely. I would
Yeah,
love to be there.
thank you, thank you.
Hmm.
Yeah. Okay, sir. I actually joined little early because last time I couldn't join. I came
Okay.
late. I came
Okay.
late last.
हाँ नहीं I was watching the videos today. Okay, actually what happens in this.
Yeah, yeah. And
हाँ,
I had reviewed two of these papers, so I was
right.
more interested. Discussion of
Yes. हाँ,
this
true.
Delphi method I heard for the first time. कि क्या है?
हाँ this Delphi method I had reviewed.
I know, I know. I had also reviewed. So when I got the article, I actually delved into the literature and I found out what is this actually,
Yes,
what it
yes.
stands for. I heard this term for the first time. कि
ओके।
क्या
नहीं
चीज है?
वो आई वाज द एमएस, तो थोड़ा बहुत वो हॉस्पिटल एडमिनिस्ट्रेशन करते थे, उसमें वन ऑफ द थिंग्स वाज
हाँ हाँ,
डेल्फी
yeah, yeah.
मेथड फॉर
Then
फोरकास्टिंग
I
एंड ऑल
found
दैट।
out that it is a universal thing. It's applied to a
यस यस
lot
नहीं
of things.
it actually started off with the business and all that.
Yeah, yeah. And very innovative. I mean, very
यस
scientific sort of thing.
यस ट्रू 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 ट्रू।
कि अगर हम चेंज करते हैं अपना प्रैक्टिस, then it actually makes sense कि नहीं,
यस ट्रू यस
how your colleagues do. Very nice, very good.
ट्रू ट्रू।
Yeah. अच्छा हुआ, at least we got some time to
चैट। ट्रू 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 सर। मोहन अब्राहम।
ठीक है, ऑफ ही कर देते हैं कैमरा।
हाँ ठीक है सर, ठीक है। राइट,
ओके,
ओके सर, बाय सर, बाय।
बाय।
Good evening, everyone. Good evening, Anand.
Good evening, sir.
All well?
Yeah, good.
गुड इवनिंग सर, गुड इवनिंग।
Good evening, Arvind. How are you?
बस एकदम बढ़िया सर।
Subhashish, are you
Yeah,
around?
good evening, sir. Good evening.
Subhashish, I want next Abhigyan to be, you will be the person who will decide the
Articles.
articles
Yeah.
and you will be one of the moderators.
Okay. Thank you.
I am telling you in advance. So
Yeah.
that
Okay.
it will be in July 3rd Thursday, most likely,
Okay.
unless something is here and there.
Okay.
Yeah. Vijay, all well?
Sir, good evening, sir.
Good evening. Good evening.
You just reached, sir, home.
Okay.
Good evening, sir. Good evening, sir. Good evening, Arvind sir.
Thank you. Good evening.
Evening.
Anand sir, good evening.
Good evening.
Yeah, last day I couldn't join, so today I joined half hour before.
We had our chat also.
Yeah, we had a lot of discussions.
Yeah.
So he said, oh, it's already started. Is it? So then we tried this and it worked. The one case doesn't mean anything, but it makes sense to try to delay the delivery by amniocentesis, and or if the baby descends down into the lower segment, then maybe surplus.
Okay.
But having said all this, you should have very good antenatal care and proximity of the patient to the hospital. They cannot be 400 kilometers away. Then there may be rupture of the uterus or something. You know.
Right.
Antenatal care is also, I mean, all the high risk babies should go close to the obstetric center and the surgical center.
Right.
The corollary is also done too for patients with oligohydramnios. So they try to push it by maintaining with amnio infusion.
What are the conditions where you get amnio fluid reduction?
Mostly it's for PUV with otherwise not very bad prognosis, but borderline sort of thing, which they try to push when they've not done antenatal shunts or anything like that.
You have done some
they're all
cases?
anecdotal. No, I am not. It's only read up about it. The polyhydramnios have had 2 patients long back, where the obstetrician maintained the pregnancy by pushing it by amniocentesis, periodic amniocentesis. I think they had 4 or 5 sittings before finally reaching term. This was in, I think, 2000 and probably 2012, 13.
I think good pediatric surgery has to have a good support of fetal medicine and good neonatology. Then pediatric surgery really shines, because the difficult part of pediatric surgery is, I think, neonatal surgery only. That is the most difficult. Premature babies and near-term babies.
Sorry, I think I had muted myself when I was saying. So I had this couple of patients with the 2012 or 13, and the obstetrician managed to push it by doing 4 or 5 sittings for esophageal atresia.
We can start now.
Yes.
It's 8 o'clock and let's start. Manoj, you can start.
Participants are increasing, sir. Yeah. Okay, sir. Thank you.
Yeah.
So good evening, all of you, senior esteemed colleagues and senior teachers of IAPS. We welcome you all to the second episode of JIAPS Abhigyan. Following the first successful episode we had last month, where we had very thought-provoking questions and very valuable insights from senior members. So we hope to have many stimulating discussions also in these manuscript. So before we start, I would like to invite our editor-in-chief, Dr. Asif Shah, for his inaugural welcome words.
So thank you, Manoj. The idea of JIAPS Abhigyan is to promote JIAPS. People start reading the articles in JIAPS, start contributing good articles in JIAPS. So that is in nutshell. Along with that, it is always good to hear from the author what exactly they want to say about any particular topic or article what they have written. Many times when we read, we have some queries and confusions, and we may not be able to ask the author. So this gives an opportunity to us to ask some questions which we have in mind, and it will help all of us. Another thing is it's like a closed group, closed forum where all of us are friends. And if there are any questions, queries, you can ask anytime. Author, co-author, everybody can participate. There is no watertight line. It has to be done like this only. So going forward, even the case selection, article selection and everything will be done by the moderators, whoever is being selected. So I was talking to Subhasis Saha that the next episode of Abhigyan, which we will have in the month of July, the article selection will be done with Subhasis and one more moderator. They will select the articles and then they will be presenting in this particular forum. So feel free to contribute in whatever way you can. If you have any suggestions, you can give it to us and we'll try and implement as much as possible. Even if you, the infographics, Kirti was asking since long, but somehow it was not happening. Now we have got quite a few infographics from the author. Going forward, if your article is not even selected from JIAPS Abhigyan, even if whatever means, even if we get infographic, we'll try and publicize it so people go and read the article and quote wherever possible. So this is in general what we are planning to do, and let's continue. So I'll hand it over back to Manoj to continue. Please, Manoj, continue.
Thank you, sir, for your wise words. We have three very interesting manuscripts in this session lined up. And for that discussions, we have two moderators, Dr. Arvind Sinha from AIIMS Jodhpur and Dr. Sandesh Parelkar from Mumbai. Both of them, they don't need any introduction, obviously. They are part of editorial board, senior editors of Creative. So I would like to hand over the proceedings to the moderators to invite the first speaker.
Yeah, only one suggestion to all the delegates who are present over here. Put your name instead of, AS2022 or iPhone, at least Alpha is written. So put your name so that, we know who is present. Please continue. I don't see Sandesh. Is Sandesh around? I don't see him. So I think Arvind, you will have to
Arvind can start.
continue.
Yeah, I'll do that.
Sandesh. Yeah.
Okay. So good evening, everyone. I think let's start off with this session. And the first paper is polyhydramnios secondary to esophageal atresia, cervical cerclage, and serial amnioreduction to prolong gestational age in select cases. Dr. Narasimhan will be telling us about this case. Over to Dr. Narasimhan, sir.
Actually, this is not something which we have done. It's the fetal medicine people who have done the job. The suggestion from in the meeting, fetal medicine meeting, was that we should delay the delivery so that the baby is good weight. And because of IVS pregnancies, parents will really go hard on you to save the baby. So that's why we tried it. One case doesn't mean anything, but I think it sets us to think that if you get a good-sized baby for with any of these neonatal anomalies, they behave better. I was just telling that if the baby is 2.5 kilos and above, we have very less trichomalacia or other complications after surgery, neonatal surgery. So it is worth delaying the pregnancy, especially if it descends down into the lower segment. This baby descended down into the lower segment. That means if there's a lower segment is effaced, the baby will deliver very soon. So that's why it was the obstetricians asked me whether we can delay and aspirate. They were aspirating about 2.5 liters per 2 weeks. So it's quite a lot of fluid to be aspirated. But the child, the mother and the fetus, the mother has to be very close to the obstetric center because if any complication occurs, if you want to save the baby, for example, abruptio occurs, you have to operate very soon so that the fetal hypoxia doesn't set in. So it is a very important concept that if you have high risk baby and you want to do something specialized, they should be referred or they should be in centers close to pediatric surgical facilities, good neonatal surgery facilities. So we should embark on these things in a proper or in a planned way. Otherwise, it will be a lot of mortalities and uterine ruptures and other complications. This cerclage itself is done very early on in normal obstetric conditions. This cerclage has been done after the second, late in the second trimester. So this is very different from the cerclage the obstetricians do for incompetent os. So that's why I put up the paper. The gynecology obstetricians were hesitant to put up this paper. I don't think one case means anything, but if you all get cases, you can try.
So, what so just to start off, what were the factors that actually made you consider cerclage in these cases, in this case that you did? So you muted.
I said specifically, no, that when the patient has polyhydramnios, of course, in the fetal anomaly scan, they will look at polyhydramnios and then monitor the patient closely. If the polyhydramnios becomes tense, they will, of course, aspirate and they bring down the polyhydramnios. Because in this patient's stomach was also not seen, the suspicion was strongly of esophageal atresia. The baby, when it descended and effaced the lower segment, that is when the cerclage was done. Because so effacement of the lower segment occurs just before onset of labor. No? So if the baby had gone uterine contractions, then the uterus will rupture. So it needs constant monitoring. These patients need close monitoring.
Any cervical length that we considered when deciding yes?
No, I have no idea. See,
Okay.
Giorgio is one big shot man. He won't talk to you. He talked to me with great respect when the baby survived. He was saying, oh, you guys are fantastic. I never knew you guys can do such a wonderful thing. The mother is so happy. See, there are two classes of patients. One is the IVF patients who are very special, and the routine patients. IVF patients are special. We have a huge population of IVF mothers. So, for them, if the baby is alive, they will give you 10 whiskey bottles also. No problems. They are so happy because they value the child. So this mother is 36 or 37 and she was very happy.
And any questions from the members? They can put it in the chat box. And sir, regarding sir, the paracentesis, the amniocentesis, how were we following them up with the amniocentesis? Were we doing the amniotic fluid index, or how did we decide?
I wasn't.
Okay.
I wasn't doing only volume. Volume to reduce the volume of the uterus only. That's what Giorgio told me. I don't do these. Fetal medicine procedures are done by fetal medicine people. The only time they will call you is when there is a need for, or they think something is wrong. Like if there is an abruptio, the mother feels that there is some discomfort and she is feeling something, she will come to the emergency. And for example, in this case itself, there is an abruptio or the uterus is contracting and the uterus is rupturing. The mother will come to the emergency, obviously, with some symptoms. So immediately they will monitor the baby. And if the fetal medicine guy is on call, he will immediately pick up that there's something wrong and do an emergency Caesar. And then you will get called in the middle of the night for the condition. No? So you'll really have to have 24 hours fetal medicine unit available and neonatal surgery facilities available. Then you can really embark on complicated procedures.
So basically, if we have to summarize, any patient where there is polyhydramnios and you want to prolong the gestation, then this is one of the options. One needs to try in few more patients before we can say it definitely helps.
No, cerclage may not be necessary. Only amniocentesis may be good enough.
Okay. So, okay. Any other point you will like to highlight?
I don't think it's very complex. If you have a good fetal medicine unit, you don't have to do anything. You just say that I want the baby at 36 weeks. Please ensure that you aspirate and you manage the patient. They will do everything.
Okay. So, yeah, Sandesh is finally is able to join. Sandesh, Dr.
good evening.
Narasimhan has completed his presentation. Some discussion has happened. If there are any queries which you had thought about, you may ask him.
The-
Yeah,
I'm sorry I missed your presentation, Dr. Kannan, but I'm sure it's
No,
a
no.
fascinating way of managing a child with suspected esophageal atresia, and would be interesting to have similar cases managed, especially in settings like ours. Uh, I wanted I had one specific question. Is it, what was the indication for LSCS in this child? Is it purely because of a high risk sort of, or a planned LSCS? Was it planned for obstetric reason?
I don't know. So, see, he removed the cerclage and he did the cesarean after 37 weeks because I maybe the mother preferred. I have no idea. That's why I said no. The decision to manage the patient postnatally, only the baby will be handed over to you. The only decision consultations will be taken for what you think is appropriate. Most of the management will be done by fetal medicine. No, we are not.
Correct.
I don't recall. So they told me that this is fixed for an elective cesarean, and then what would you like to do after that? Then we normally take about 24 hours to evaluate the baby because the PDA status, cardiac status, and all that, and then counseling. The next day only we will operate. Next day we operate. So
so do you
that's
have
all.
joint consultation like,
Oh, we have a weekly meeting.
okay,
But the most of the conditions are cardiac and vascular abnormalities and all that. So pediatric will be only dilatation of the pelvis or abdominal wall defects or polyhydramnios. Those are the kind of cases that will be discussed. And if it's a problematic case or something, or if it's a VIP, that fellow Giorgio will ask me on the corridor or in coffee room, what can I refer the patient to? That's how this patient came to me.
okay.
It's not.
It's not a standard practice.
No, generally they will. Uh, See, I don't know. Their documentation is secretive. They don't let us see. I have a patient who came with valves at the age of 5 and their antenatal scans were normal. They didn't show me the antenatal scans. I asked them, show me the antenatal scans. They didn't show. They're a pretty secretive group of people. Most of them, they hold on to their patients, the pediatricians and neonatologists. For us
And
to, I think that must be the same experience across the world.
yes, I'm sure. And is there any ethical issues, or do you take any, do you in the
About
sense
what?
that ethical issues about these, or what kind of consent do you take when, or the gynecologist would have taken for the encerclage, cervical encerclage?
Oh, they would be taking everything because they'll one case, one litigation is $1 million. Okay,
Hmm.
I have paid some litigations, so I know what is the fees. So it is a tough thing. So actually, even fetal medicine. Once there was one patient with what is it, fetal mirroring syndrome and severe edema. I told, why don't we do fetal surgery? And Giorgio said, you want me to pay $1 million? Is it? I'm not going to have. I've referred off the patient to Melbourne. Let them go and stay there. He said. So these guys are very conscious that our practice gets limited if we get into litigation and we lose money. After that
Yeah.
you can't practice. So it's challenging to do anything in very litigant societies. I'm sure Bombay is halfway there.
Not yet.
Rasik.
No, not yet. But it will get over there. It will take time,
It'll,
but I think
it will come. It will come. There is no way we can escape all these things because the
Yeah,
more educated the patients are and the more they read a lot. No, all the patients read a lot.
yeah. I think we can go on to the next paper, Arvind.
Thank you. Thank you.
Thank you, sir. Thank you very much.
Thank you,
Narasimhan
Dr.
and- yeah.
So,
Thank you, all of you.
right.
Thank you,
Let's-
Narasimhan.
Let's go on to the second paper, which is the safety and feasibility of enhanced recovery after surgery in pediatric colostomy closure. Dr. Vidya would be presenting, I believe.
Good evening, everyone. Sir, I'm not.
Yeah, we can hear you.
Okay. Sir.
I'm making you co-host so that you can
Share this.
share your presentation.
Okay. Sir.
Yes, it's
Sir,
visible.
okay, sir.
Please carry on.
Okay. Good evening, everyone. Today I'll be presenting paper on safety and feasibility of enhanced recovery after surgery in pediatric colostomy closure. In our department of BMCRI, we have been performing colostomy closure without bowel preparation since 2012. In addition, following a department study, which was later published, we moved on to single perioperative antibiotic prophylaxis from 2010. Since 2013, we have adopted early oral feeds in abdominal surgery as a routine. Thus, since 2013, the department protocol has been to perform colostomy closure without bowel preparation, limiting antibiotic to single preoperative prophylaxis and starting oral feeds early. Hence, this study was to review retrospectively the safety and feasibility of ERA's protocol in pediatric colostomy closure. It's a retrospective observational study, included all children admitted in Department of Pediatric Surgery for colostomy closure from October 2013 to October 2023. Data were analyzed from electronic and physical medical records and telephonic follow-up calls. The continuous variables were expressed as mean plus or minus standard deviation or median, and descriptive parameters were expressed as percentage. The parameters obtained were gender, age, type of stoma, diagnosis, intraoperative proximal and distal stoma discrepancy, time to start oral feeds and reach full feeds postoperatively, postoperative hospital stay, and postoperative complications. The ERAS protocols which were implemented in our study were preoperatively detailed counseling. There was no bowel preparation, no overnight fasting, and no pre-medication. Intraoperatively short-acting anesthetic agents, single dose of antibiotic prophylaxis, non-opioid analgesia, and avoidance of contamination by packing proximal stoma till mobilization. Postoperatively, there was no NG tube insertion. Early oral feeds were started, that is liquids within 24 hours postoperatively, and every 4-hour increment of feeds. If there was any intolerance, then we slow down the progression. Avoidance of water and salt overload, and no drains or catheters were inserted. All patients received a prophylactic antibiotic dose of amoxicillin with clavulanic acid, amikacin, and metronidazole. Colostomy closure done with interrupted extramucosal single layer using polygalactin while preventing contamination by packing proximal stoma until mobilization. Early enteral feeds were started, which included liquids within 24 hours postoperatively, with every 4-hour increments of feeds until full feeds for appropriate age was reached. If any intolerance occurred, like vomiting or abdominal distension, then feeds were slowed down to previously tolerated step and then progressed gradually. If intolerance continued, feeds were deferred for another 24 hours. Coming to results, total of 90 patients were included in the study, among which 80 patients were of ARM cases, 3 of NEC, 2 of Hirschsprung's disease, 5 were due to perineal injury. Among these, 67 patients were less than 1 year, and 11 patients ranging from 1 to 5 years, and more than 5 years were 12 patients. Male to female ratio was 2.4:1. There was no luminal discrepancy between proximal and distal stoma in 66 patients, and 19 had minimal discrepancy of 1.5:2. 5 of them had a significant luminal discrepancy of 4 or more times. Full feeds were reached within 2 days in 79 patients, 71% of these being within 1 day. In 11 patients, there was delay in reaching full feeds, mostly because of the ileus. Postoperative hospital stay was 2 to 3 days in 62 patients. Of the remaining 22 patients were discharged on 4th or 5th day. 6 patients stayed for more than 5 days, ranging from 6 to 13 days. These 6 patients were due to complications warranting the prolonged stay. We noted surgical site infection in 6 patients, all of whom were managed with regular wound dressings. 4 had developed a fecal fistula, 2 of which resolved spontaneously. 3 children among these had no or minimal luminal discrepancy. 1 had a discrepancy of more than 4 times, who presented after 20 days and was responded to conservative treatment. Among these 4, 2 children, both were infants with ARM and no luminal discrepancy, developed fecal fistula on 3rd and post-op day. 1 was re-explored and revised with uneventful recovery. Other patient was converted to stoma and discharged. To discuss, IRAS's multimodality protocol comprising preoperative, intraoperative, postoperative elements to accelerate the recovery of patients undergoing surgery. Although 19 IRAS elements have been established in adults, we have implemented 12 in our study. There is no consensus in the literature regarding preoperative mechanical bowel preparation, duration of pre and postoperative antibiotic administration, routine NG decompression, use of analgesic, and time of postoperative oral feeding initiation in the pediatric surgery patients. Comparing our study with the other studies, our study wound infection rate was 6.6%, whereas other study by Chandramouli B et al., who had used conventional bowel preparation, had a wound infection rate of 12%. And Sursak et al., who had used conventional feeds, that is starting off feeds after bowel sounds were heard or after baby pass stools, the wound infection rate was 23%. And in Francine D et al., who had used conventional antibiotic, had a wound infection rate of 14%. Our patients were discharged early with a mean of 3.3 days. This reduced the length of stay would transform into reduction of length of cost and stress on healthcare facilities by increasing bed turnover. In a study by Uday Bhaskar sir and Sundaranjan madam on IRAS in colostomy reversal, they found that complications were lower and hospital stay was lesser than conventional protocols. Since this was a retrospective study, there are certain limitations which preclude absolute conclusions. Although not a prospective study, general protocol of IRAS has been followed in the management. To conclude, application of IRAS protocol in pediatric stoma closure is safe and feasible. There are no added postoperative complications, and there is observed decreased postoperative length of hospital stay. These are my references. Thank you.
Thank you, Dr. Vidya. A wonderful paper and presentation. Any questions? You please can type it in the chat box. We'll take it up with the authors. As far as the elements concerned, you said there were no bowel preparation and all that, and you used packing.
Yes, sir.
So did you once you removed the packing and all that while doing anastomosis, did you have any incidents where you had a gush of fecal matter coming or something like that?
No, sir, we did not have anything like that, sir.
Okay.
Until mobilization, we had packed with the betadine soaked gauze, sir. After mobilization, we had done anastomosis, taking it little outside, and there was no gush of stools or anything, sir, anytime.
And did you have?
There are,
Yeah. Yes,
sorry.
sir. Paralika,
There
sir.
are a couple of questions. Before I ask those questions, was there any difference in the transverse colostomy closure vis-a-vis sigmoid colostomy closure
Sir, we had 5
regarding
cases of
complications?
no, sir. 5 cases of transverse colostomy, which was among them 2 were due to Hirschsprung's disease, which were operated outside, and 3 cases of NEC. But there were no complication in the transverse colostomy cases, sir. The sigmoid only had among them 6 cases with wound infection and 4 with fecal fistula.
Okay,
All
thank you.
transverse stoma were no
No
complication.
complication. Thank you, Dr. Vidya. Now,
Thank
Dr. Partha Pratim Gupta wants to know, colostomy closure is listed as contaminated surgery. It is very brave to take up this protocol. Is it really the most important to be able to discharge as early as possible, or overall safe surgery is important?
Sir, we have discharged the patient once child is completely stable, tolerating full feeds for appropriate age, and once we have noted there was no any wound infection or anything, sir. Once the baby is stable, only we have discharged. So it was already we had implemented the protocols. We just looked back for the
Reviewed retrospectively. That
reviewed
is what you are
respective.
saying.
Yes, sir. And we found out the result to be good, so we have been continuing the same protocols, sir.
Okay, thank you, Dr. Vidya. Dr.
Thank you.
Rasiksha wants to know, how often do we see fecal fistula after colostomy reversal?
Sir, other study which I saw, like two cases, two studies which showed around 4 to 6% of fecal fistula in post colostomy reversal. In that, in 4%, they had done the same ERAS protocol with no bowel preparation or anything. But 6% was noted in the cases which they had done bowel preparation and also keeping NPO for until bowel sounds were heard.
Just
Dr. Rahul.
on fecal fistula, I
Huh,
mean, we have hardly seen after stoma closure. I just want to know from the people present over here, do they see 6% just or less? Just for my understanding, 6% looks quite high to me.
Yeah.
Anyway, let's continue. We
I
can
think,
discuss this maybe later in
yeah,
the
I think in
higher-
routine cases, we not really remember any fecal fistula for a long time. Yes.
Exactly. 6% quite high.
Can I just add in?
Yeah, please, Anand.
So we have, this is a retrospective study, and being a teaching institution, it's varying consultants of seniority and postgraduates who are doing the procedures. There are definitely have going to be some limiting factors of technical issues. So
Okay.
we do not say that, claim that the fecal fistula is less or more, and it could be due to either a technical issue or maybe the ERAS protocol per se doesn't seem to have made a difference.
Okay.
So most probably it might have been due to a technical issue or maybe an wrong because when they calculate the discrepancy, and if it is very significant discrepancy more than 4:1, sometimes they tend to delay the feeds. So sometimes in calculating, somebody might have been a little more aggressive and thought it is a lower ratio and started early. So there could be these sort of confounding factors since it is not a prospective study.
Okay. So if I have to ask you further, that ERAS protocol, whatever you have implemented for last few years, prior to that also there were incidents of fecal fistulas. Basically, Anand, we hardly see, so it look little on higher side. Anyway, we can continue with the discussion on other parts.
I think
I
Can I
think
ask one question?
another questions that the chat box is asking is about the element of early feeding. So we would like some clarification on, let's say I think initiated early oral feeds within 24 hours. So people are asking whether any percentage of cases required NG tube insertion in the post-operative period after you've initiated the feeds.
Sir, as I've looked in the previous records and checked, sir, there was no insertion of NG tube in any of the cases. Only for over 24 hours, there was again like we withheld the feeds, and then later once there was no vomiting or distension, we started with liquids and then gradually increased every 4th hourly, sir. There was no NG insertion in any of the cases.
Sir, I would like to add, actually, this we started doing this early feeds from 2010. This was like my thesis topic because I saw in gastro, even for Whipples, they were starting early. So I had asked Anand sir whether we could start early feeds in our children, especially colostomy closure, but it's a lower one. So from 210, we started following this protocol. So what we do is if we do a stoma closure today, so we keep the NPO, baby NPO today. The next day morning, probably after 16 hours, we start the feeds. And what feeds we give is, we ask the mother not to overfeed the baby, give small feeds. And we also see if there's any distension or not, and gradually increase the feeds. If there is distension, we withhold the feeds for 6 hours or that another 4 to 6 hours, and then again start small feeds. So by the time they reach full feeds, it will be either 48 hours or 72 hours. And some children who reach full feeds by day 2, we discharge them early, and some children, they may take day 3. So, but we have seen that early feeds before, like you asked, before 210 also, 2010, we were following the conventional method where we were keeping the baby NPO for 5 days. Compared to that to now, on a note, what we have seen, there is not much difference. But the records of before 2010 are not available to review. So that we were not able to do, sir.
Right.
Sir,
Yeah,
good evening, sir.
Dr.
May I
Niaz.
comment?
Yeah. Yeah, Dr. Niaz, please go ahead.
Okay, sir. Good evening, sir. Very nice presentation. Actually, the same early feeding, the early enteral feeding, we did 2 randomized control trials at Kalavati, sir. So it was done under Dr. Rajchaudhary sir's guidance. So we started with the early enteral feeding, a protocolized feeding within 24 hours. And majority of our patients, were rather all the patients, they developed, they went on to full feed within 48 hours, and we were able to discharge them, all these patients. So there was no extra, what we can say, or complication rates in both the arms, both in those who had conventional feeding and those who had early enteral nutrition. So this study also, I think, just reiterate that fact that early enteral feeding can be established in patients with colostomy closure, because and early enteral feeding does help in early recovery. That is what I can say. And Dr. Rasik sir, regarding that fecal fistula in colostomy closure patients, sir, I'd just like to give a few what we have seen at a teaching institute, because the residents generally do colostomy closure, so there are chances of fecal fistulas in them. We don't know whether it is a technical issue or whatever it is, but we in teaching institutes, we do see some fecal fistulas in colostomy closure patients.
Okay, noted. Thanks.
One just additional thing in respect to Dr. Suhas's question about suture material quality. With respect to scheme patients, in our institute, in spite of patients being scheme patients, we have this government this thing where we have a rate contract tender established for 3 years, and it gets renewed. And being in the committee, we make sure that we have only the standard sutures. So the sutures which we have are either Covidian or Ethicon, though it's a government institute. And the other thing I would want to add, which was probably missed out in the presentation, was that all our closures are subcuticular continuous sutures for the skin.
So,
Thank
Can
you,
I just
Dr.
ask
Anand.
a question?
Any-
Arun?
yeah, Dr.
Any blood transfusions is what
Just-
Dr. Bagri wants to know. Dr. Vidya?
No, sir. Only like if any anemic patients, we used to give oral iron supplements and do a surgery after 1 month or 2 months once the hemoglobin was picked up, sir, about 10 hemoglobin.
And Dr. Manoj Joshi wants to know your experience of transrectal tube after anastomosis to avoid distension and deflation. Is it beneficial? That is what.
Sir,
Transrectal tube,
sir.
a rectal tube like an
Post
NJ tube, post anastomosis.
No, sir. We have not
You
used.
don't practice.
No, sir. No, sir.
If anybody in the house, I think if the senior members who have any experience.
Just on transrectal tube, I think only if I do Hirschsprung's pull through, maybe it has some role. In colostomy closure,
No,
where the
yeah.
anastomosis generally is high, I don't think anybody puts.
Many times sigmoid colostomy is there when we close it. So when there is a lot of discrepancy, so just to, because the proximal thing is very much dilated. So it helps in early deflation and avoids abdominal distension.
So you will go across the anastomosis.
Across the anastomosis, a soft tube.
Okay.
So it deflates. Yeah.
Okay. Maybe I have never done, but I think it's a good suggestion.
We generally do a single dilatation if it is required, just
Oh.
after the surgery before the reversal.
Okay.
Any other comments or questions? So shall we go on to the third one?
Yes, sir.
Thanks.
Please.
The third paper is Delphi method analysis and consensus of development, prevalent distinctive practices for biliary atresia management after Kasai's photoenterostomy, and Dr. Shravanti would be presenting.
Thank you, sir. Am I audible, sir?
Yes, you are.
Good evening, everybody. I would like to thank JIAPS Abhigyan team for giving us this opportunity. The paper we are discussing is on Delphi method analysis on the postoperative management of biliary atresia after Kasai photoenterostomy. What is Delphi technique? It is a technique used to gain a group consensus after discussing with a certain experts based on a research question. So initially, a facilitator will provide a set of questions to the selected experts based on the research topic, and the feedback is sent back to the facilitator, and they are summarized and sent back. So this process goes on back and forth for a few rounds before a common consensus has been made. This is not a new technique, and it has been used in our pediatric surgery also. Like recently, a pediatric specific ERAS protocol has been published in USA, and also a Delphi method was done for definition and cholangitis treatment and definition. So in spite of having so many systematic reviews and meta-analysis, we do not have any uniformity in the management, and that's why it's better to learn from the local experts in the field. So as we all know, biliary atresia is obstructive cholangiopathy seen in 1 in 15 to 20,000 live births, and liver transplantation is a definitive modality. Kasai sir, is somebody controlling the slides, sir?
No.
Sorry. Kasai photoenterostomy clears jaundice in nearly 50% of the patients, and survival rate has increased, though cholangitis is a common complication and has early liver failure. So various pharmaceutical agents are used like antibiotics, steroids, and choleretics, but to improve the outcome. But however, the drug of choice, duration, and dose are not variable, are not specific, and they vary between institutes. So the study outcome is to find out the postoperative management of Kasai from pediatric surgeons across different institutes in India, based in regards to antibiotic prophylaxis, use of ursodeoxycholic acid and phenobarbital, steroid usage, CMV positive biliary atresia, to know the drugs used and duration, and to come to a common consensus on the post-op management. So a standard Delphi model was used with N rounds with questionnaires to be modified after each round depending on the response. So the first Delphi questionnaire was a semi-structured interview involving 2 experienced pediatric surgeons to refine the questionnaire, and personalized telephone calls were made to the selected 25 experts. The Delphi method was explained to them, and the questionnaire was distributed only after obtaining their verbal consent. The questionnaire was initially emailed in December 2022 with multiple follow-ups over 2 to 4 weeks. The second questionnaire was influenced by the criteria that garnered a consensus from most participants. The outcomes were disseminated, and the second survey assessed alteration in the current practices and the reasons behind such changes. It was administered in a similar way via email in March 2023, and after that, 2 remainder emails or phone calls or WhatsApp messages were sent 2 to 4 weeks later. Further questionnaire rounds were not performed, and consensus was not have achieved regarding some issues, while no new information was expected. So the salient points of questionnaires on the post-op management were: from the questionnaire 1, the duration and drug of choice for prophylactic antibiotic, duration of phenobarbital and UDCA use, which is justification, use of steroids, duration and dose, the antiviral drug for CMV IgM positive patients, and the timing of follow-up for LFT and HIRA scan, and number of Kasai done by the experts in a year.
The second questionnaire depends on the practice change based from the first questionnaire. The questionnaire was answered by 17 out of the 25 pediatric surgeons. Out of them, 50% are doing 5 to 10 Kasai per year, and the 25% are doing 10 to 15 or more than 15 Kasai procedures per year. Prophylactic antibiotics given by the majority. For 41.2% have given it for 6 to 12 weeks, more than 12 weeks by 35.5%, 1 to 3 weeks by 11.8%, and 3 to 6 weeks by 5.9%. And the drug of choice was trimethoprim plus sulfamethoxazole in 60%, whereas the rest have given amoxicillin or cephalosporins. The rationale behind the use was to prevent cholangitis. Phenobarbital was given for less than 3 months by 52.9%, and was not routinely used in 41.2%, and was given for more than a year by 5.9%. The justification by majority for not using it is that enzyme induction is not required during the postoperative period. UDCA was given for less than 3 months by 47.1%, for 6 months to 1 year by 23.5% each. This is to enhance the bile conjugation and excretion. The reason behind the drugs being given was mentioned as institutional protocol by many. The steroids were given by 52.9%, out of which prednisolone was most common. It was given for 6 to 12 weeks by 36.4%, or 1 to 3 weeks by 36.4%, and for 3 to 6 weeks by 27.3%. The usual dose given postoperatively was 2 milligram per kg per day, and in cases of cholangitis, it was 5 to 10 milligram per kg per day. In CMV IgM positive cases, 58.8% prescribed ganciclovir for over 6 weeks. LFT was repeated after 1 month by 70.6%, followed by 3 months by the rest by 17.6%. HIDA scan was not prescribed by 70.6%. For the second questionnaire, the summary of the first questionnaire was sent to all, and change in the management was assessed. Significant number of participants were willing to change the practice. In the antibiotic usage, 75% decided to retain the existing protocol, while 25% opted for 6 to 12 week duration as opposed to previous practice of 3 to 6 weeks or 1 to 3 weeks. Phenobarbital and UDCA, 16.7% of the respondents modified their approach and favored a duration of less than 3 months in previous contract of their 1 year practice. 91.2% exhibited consistency in the use of steroids, and 16.7% reconsidered ganciclovir for IgM CMV positive patients. The summary of the result was that antibiotic prophylaxis were given by 6 to 12 weeks by 47%. The drug preferably used was trimethoprim and sulfamethoxazole. Phenobarbital was given for less than 3 months by 52.9%. UDCA for less than 3 months by 47.1%. Steroids, that is prednisolone, for 1 to 3 weeks by 52.9%. And ganciclovir for CMV IgM positive patients for 6 weeks by 58.8%. And LFT was done postoperatively at 1 month, and HIDA scan was not done by 70.6%. Coming to the discussion, the use of antibiotics is generally proven beneficial in the literature. However, the drug of choices were sulfamethoxazole and amoxicillin, or third generation cephalosporins, but there is a variation in the duration and dosage. Similarly, phenobarbital and UDCA chloridetics being used. However, some literature says that though phenobarbital helps in removing bile salts that cause jaundice and itchiness, but it's as an adjuvant of no apparent benefit in the postoperative period. And few experts preferred UDCA over phenobarbital, and it clears jaundice and improves bile flow over 3 to 6 months. In CMV positive biliary atresia, 10 to 35% it is seen, and it has poor outcome because of bile duct destruction and paucity and ischemic vasculopathy. And ganciclovir at 6 mg per kg per day over 6 weeks is generally accepted. Steroids in biliary atresia are given because 30% of them have abnormal expression of HLA-DR antigen and adhesion molecules like intercellular adhesive molecules or vascular adhesion molecules. And also there is a marked systemic inflammatory response for at least up to 6 months. Multiple papers accept these, but however, there's a debate lies between the use of high-dose steroids versus old-dose steroids and further duration. So the study was done to get an overview of the postoperative management of Kasai at various institutes in India, and the proposed management from the study is not a recommendation, and it needs multicentric studies to bring a uniformity in the management. The strength is that though they are individual opinions, but as a group, they have more strength, and it is easy to conduct, reproducible, and small guidelines can be sent to primary care centers or refer back units where a pediatric surgeon may not be available for a regular follow-up. So this method can be used in diseases with variable management, and it also emphasizes the need for multi-center studies, and maybe it can be used to derive national regional consensus and develop a standardized protocol. These are some of my references. And I would thank all the seniors and experts from various institutes who have participated in the study and helped achieve the outcome. Thank you.
Very wonderful paper. And any comments regarding the paper from anyone? Okay.
Can we have,
yeah.
Is it essential that to have only two questionnaire, rounds of two questionnaire? You can have multiple, isn't it?
Yes, sir, we can have multiple rounds of questionnaires, but
Any number of rounds specified in the Delphi technique to get optimum opinion or to formulate a protocol?
at least it should have minimum of 2 rounds, sir, but the number of rounds increase as the variables increase, sir.
So do I understand that if we add a couple of more rounds, it might be more useful?
Yes,
so not
sir.
only biliary atresia, in other entities or pathologies as well.
Yes, sir. The more number of rounds, it'll have a better outcome, sir.
Regarding the rounds, did we have any stopping criteria that we had predefined stopping criteria that this is the time we'll stop?
No, sir, we did not have a predefined criteria like that. But because in the second round, many of them have given no change in the practice. So we really didn't have any further questionnaire to go ahead. So we had to stop at the second round, sir.
And there is a question by Dr. Bagri in the chat box. What about vitamin E, vitamin D, and multivitamin drops? Do you recommend those? Or was the questioner asked about these drugs as well?
No, sir. In this particular study, we did not ask about the multivitamin supplements, sir. But in general, we usually give them to the patients, sir.
Any questions about the dose of steroid that we used across India? Because there's varying doses, 2 milligram, 5 milligram, and some people even have higher doses. So did we have any questions about the dose of steroids that we used?
We had put a question, sir. Majority of them gave it as 2 milligram per kg. And when the patient presented with symptoms of cholangitis, it increased to 5 or 10 milligram per kg per day, sir.
I think very nice paper overall. And lot of queries I think people had, we had discussed on IAPS academic group also about all this. So in summary, what will you like to say? Most of the people probably practicing in a particular way, like, antibiotic, how long, steroids, how long, just summarize once for everyone's.
So from our study, we propose antibiotics for at least 6 to 12 weeks duration, sir, post-surgery. And phenobarbital and UDCA should be given for at least 3 months. And in CMV positive patients, it should be given at ganciclovin should be given at 6 milligram per kg per day for at least 6 weeks. And steroids are given for 6 to 12 weeks at 2 milligram per kg per day, sir. And LFT as a follow-up is repeated at 1 month of post-Kasai. And HIRA scan is not usually done, sir, for follow-up in the post-operative period.
Nice. Any more questions?
So just one small comment from my side, Dr. Rasik.
Yeah, please.
Yeah, so the main target of this paper was to develop a consensus. We all know that a major problem amongst different centers who are doing surgeries, we cannot control the type of patients that we get, but we can control the post-operative or the overall management protocol of these patients. If we do that, whatever series that we have across all the hospitals in India, they become comparable. And in future, if somebody has to do a multi-center trial, all those patients can be grouped into a cohort, into various, case control kind of arrangement, and then you can do the analysis and, come with the national data. But currently that cannot happen because we all follow our individual practices. There are departmental protocols for almost every other disease, which actually is a variation within the department itself. So in the same department, there can be two people following different schemes of management. So what this paper says that if we sit down on a round table, talk to each other, tell us each other that I do this, you do that. Okay, I justify my way of doing it and you justify your way of doing it, and let us see that if we can come to a common ground and apply a common methodology for a patient. So if you do it at a departmental level and then inter-institute level and then at all India level, you will be able to achieve a consensus very easily. I feel that if IAPS wants to do a consensus meeting, this is actually the method of achieving a consensus on any pediatric surgical condition, whether it is biliary atresia, whether it is PUJ obstruction, whether it is choledochal cyst or any other condition, any surgical condition. And once we follow a common protocol, we have our standard treatment guidelines, but they are like kind of, the basic minimum thing which needs to be done by the surgeons and not as a standard protocol. So this is one way which the IAPS can apply, have a roundtable conference meeting with experts during the national conference, maybe one disease per year, and then in few years time we will have standard national protocols, the way the NICE guidelines are there, or the AUA guidelines are there. They are all formulated by this method only. So that's the way to go for it. And I mean, this thing should be studied in more detail. Thank you.
Good. I completely agree with you, Ravi. Like as a fellow, when I was working in US, so they had standard protocol for each and every disease. So post-operatively or pre-operatively, I have to just open that book, read in that, whatever is written, just do it. And all that 6 consultants, staffs, they had sit down together and form the guidelines, what they will like to do. Feed on day 1, day 2, day 3, whatever. Everything was written in that small booklet. And similar booklet was circulated by Dr. Ramchandran at some point. But I can't find that today. But something which can be taken by the residents when they are doing post-graduation and they just follow it. That life becomes much simpler.
Much simpler. And one more thing to add is that this can not only be applied to specific post-operative management or pre-operative, you can even apply, say, for a set of investigations. Suppose you have a portal hypertension patients, everybody will process that patient pre-operatively in a different manner. There is a different set of investigations. And then a lot of information is missed, a lot of information is not given. So you can select one particular component of a disease, whether it is pre-op investigations, intraoperative procedures, or post-operative drug management, chemotherapy, and other things, as a separate modules, and then discuss and draw a consensus.
Agree. You can, moderator, you can take over. I think we are done. Then the vote of thanks by Vijay.
Yeah,
There are a couple of questions in chat box here.
Yeah, please continue.
I think one of the questions is based on STG IAPS obviously can be updated based on consensus. I think that's a comment which is coming in. And based on multi-center studies and based on other higher evidence levels in literature. So what I think Dr. Manoj is suggesting is we can have small groups and discuss pre-op, as Dr. Ravi Kanodia suggested, have groups who are discussing, let's say, pre-op, intraoperative, and post-operative management. Each person takes out the literature and we come to a consensus, small working groups, and that can be the way forward. Right. Any other questions and comments, sir? Parilka, sir?
No, I think we should have this kind of consensus in all possible topics. And I congratulate Dr. Ravi Kanodia for doing this as a first step. And let's hope that we have this kind of statement, our own guidelines to help all of us. Thank you.
Dr. Sailesh is there actually. He designed this study. I don't know if he wants to give some last comments.
Thank you, sir. Can I make a comment?
Please go ahead.
Yeah. Actually, like when I started doing biliary atresia, so that was the problem. There was no literature that can guide us like what to do and when to do. So everyone was doing differently, and the systematic review and meta-analysis was also at the end of the conclusion that there is no clear cut benefit. Like there's a start trial on steroid on done in US. At the end, it mentioned that there is no clear cut guideline. So like I thought that we are doing at a higher like high volume center, and some surgeons people are there who are doing like 1 or 2 biliary atresia, then it's more difficult for them to like uh, go ahead with any complication or any protocol. So we thought that that is a good thing to join all the experts and make a consensus, so at least it can guide the surgeons who are not doing routinely. They are not experts, but at least they can uh, get the expert guidelines or the guidance through which they can continue the treatment. So that was the aim of this study. Thank you.
I think cross section of the current practice definitely has been brought out with this paper. I don't think there are any more questions. Can we pass it on to the IAPS office and coordinators?
So thank you all our speakers, Dr. Narsimhan, Dr. Vidya, Dr. Suravati, and their mentors. And thank you, Dr. Sandesh Parilkar sir, Arvind Sinha sir, Dr. Manoj Joshi, and our esteemed editor-in-chief for providing us this wonderful platform where we can redissect the papers published in the JIAPS for the maximum benefit of all the IAPS members. Next meeting most probably we'll have next month, where the papers will be, as already said by sir, will be moderated by a few of our people. And thank you all, and thank you to the IAPS president and the secretaries are also, I think they're not present, but thanks for providing the Zoom platform to us. We can close if Dr.
Thank you all. Good night.
Yeah, please, we can
Thank
continue.
you. Thank you, sir. Thank you. Thank you.
Thank you very